Good evening again. The fractures of the radial head account for 30% of all fractures involving the elbow joint. Most of these fractures are stable, non-displaced, and or minimally displaced fractures. In 1954, Mason provided the initial classification of radial head fractures. Most of the fractures were type 1, 73%, and the rest were type 2 and 3. In 1962, Johnston added type 4 fractures, which was any of type 1, 2, or 3 with comminuted fracture of the radial head in association with elbow dislocation. Broberg, Murray, and Hodgkin further quantified the amount of displacement in type 2 elbow fractures, while Riner suggested that the stability of radial head fractures may be based on whether there is a cortical contact between the fragment or not. From the biomechanics of the elbow, we know that the primary stabilizer of the elbow are ulnohumeral ligament, medial collateral ligament, and lateral collateral ligament, while secondary stabilizer are radial head, joint capsule, common flexor and extensor origins. In a study by Tamura and Roidis with MRI evaluation after radial head fractures, were found that medial collateral ligament were associated with 54% of the patients with radial head fractures, while radial collateral ligament was found rupture in 80% of the cases. Both medial and lateral collateral ligament were found ruptures in about 50% of the cases. In order to select the best treatment option for these fractures, several factors or parameters may be taken into account, such as fracture stability, displacement between the bones, articular involvement, and the presence or not of ligament injuries of the elbow. Many parameters or many factors are not taken into account while using our classification systems, such as osteopenia, articular impairment, radiocapitellar malalignment, and metaphyseal bone loss. These factors help to guide a treatment decision on a patient-by-patient basis. There is a good evidence that undisplaced or minimally displaced radial head fractures without a mechanical block during forearm pronation, supination, or flexion extension can be treated conservatively with excellent end results. The treatment for type 1 fractures is a conservative with a sling, aspiration of fracture hematoma, and infiltration with local anesthetic is a useful technique, will help in a pain relief, in edema relief, also for excluding a mechanical block to rotation from unrecognized chondral or osteochondral bone fragment. As far as the stable, partial articular displaced fractures, there is insufficient evidence to state that stable articular partially displaced fractures of the radial head are best treated with open reduction and internal rotation versus non-operative treatment. The amount of displacement that predicts the good outcome is defined that, as less than 2 millimeters or less than 30% of the surface of the radial head. Because of these fractures are isolated, late excision of loose bodies or entire radial excision may result in satisfactory result if residual problems or symptoms are persistent after non-surgical treatment. The terminal extension during the follow-up, the terminal extension and forearm rotation pronation supination should be mild, limited by 6 weeks after the injury. If range of motion is not progressing, a mechanical block should be excluded. In a retrospective study, the question was, is open reduction and internal fixation superior to conservative treatment for isolated displaced partial articular fracture of the radial head? There were two groups of patients, 30 and 30. One group treated conservatively, the other group treated with ORIF. The patient-related elbow evaluation score were not different in both groups. Mayo elbow patient specification score was better in conservative group. Range of motion and grip strength were similar. More complications were found in open reduction and internal fixation group because most of the complications has to do with heterotopic ossification after surgical treatment. So the statement of the paper is that no clinical benefit with open reduction and internal fixation could be found compared to non-operative treatment for isolated partial articular radial head fracture with displacement between 2 and 5 millimeters. Another article by Yon for type 3 radial head fractures. These fractures, the treatment of these fractures are more controversial. In a study with 14 patients, 9 were Mason 3 and 5 type 4 fractures. In those cases, 75% of the radial head was completely detached. A nice approach for those cases is an on-table reconstruction because it's a very difficult in situ reconstruction of these fractures. So with this technique with on-table reconstruction, 11 out of 14 elbows were clinically stable in 0, 30 degrees and 60 degrees of the flexion. An interesting thing was findings were that there was no sign of avascular necrosis in follow-up radial head fractures. Complete fracture union was found in 9 patients, partial union in 4 cases, and asymptomatic non-union just in 1 case. Here there are papers on written for on-table reconstruction. Totally there are 35 patients. Are 35 patients, 5 malunions, just 1 avascular necrosis, so it's not so bad. 1 of 35 patients with avascular necrosis for on-table reconstruction. 3 patients with elbow instability. Most of the patients, 21 patients, were found to have post-traumatic arthritis. So radial head reconstruction on table is a good option with a good clinical outcome, and these procedures should be performed in young patients with a good bone stock if stable reconstruction on table can be reached. Another patient, another papers with 24 studies, more than 800 patients, they didn't found important difference in type of conservative treatment and surgical intervention. There was a great heterogeneity in all studies. Also, different studies were using different scoring systems. So they stated that there is a lack of quality of evidence, so it is not useful to draw any definite conclusion concerning optimal strategy for treatment of type 2, 3, and 4 radial head fractures. Another paper with 144 radial head fractures. Most of the patients were Mason type 1 and 2. Type 3, 4, only 7 patients with a very good follow-up. All patients with Mason type 1 were treated conservatively with 95% achieving good or excellent result. 80 patients type 2, most of them, 96%, achieve excellent or good outcome with non-operative treatment. 48 patients with involvement more than 30% of radial head, 94% of them achieve excellent or good outcome with conservative treatment. As far as the non-operative treatment for the Mason 3 and 4, there were 11 patients in type 3 and 5 patients in type 4, 6 non-operative and 10 operative. There were really good flexion, elbow flexion in two groups, pronation, supination for type 3 and for type 4 with conservative treatment. 90 patients with a dislocation of the elbow and a fracture of the radial head. Good elbow, flexion, extension, pronation, and supination compared to other side. All individuals with a Mason 4 radial head fracture with or without a small avulsion fragment of the coronoid process did not have recurrent elbow dislocation. So it's very important findings. As far as the non-surgical treatment for elbow fracture, there is terrible triad. There is an article with 4 case reports. Select patient can be treated with a good result if after the reduction, elbow is well aligned, radial head and coronoid fracture are relatively small without a mechanical block. There are essential criteria by Matthews for conservative treatment of terrible triad injuries. So these are concentric elbow reduction, a stable arc range of motion to minimum 30 degrees of extension, a small minimally displaced radial head fracture that does not cause any mechanical block to forearm pronation supination, and a smaller coronoid tip fracture. After the reduction, an initial period of immobilization 90 degrees for 7 to 10 days. Weekly is important, weekly X-ray to see the reduction, and after 4 to 6 weeks, extension splint was used. In conclusion, the evidence in the literature regarding the displaced and complex proximal radial head fractures is controversial. Non-operative treatment of these fractures, especially in older patients, can be used with the delay radial head excision or intra-articular osteotomy could be an option if long-term results are not acceptable. Thank you.